Well, good morning and good evening, and welcome to this special webinar on chronic lymphocytic leukemia, hosted by the Centre for Community-Driven Research and Lymphoma Australia. My name's Julie McCrossan, and it's my pleasure to be your MC today. And I really want to welcome participants from the United Kingdom, from Australia, and I think we have some other countries as well. We have both patients, family members, and clinicians, and so a warm welcome to you all. Our purpose over the next hour is to provide you with up-to-date evidence-based information, to offer you the opportunity, particularly patients or people living with this condition and their families, to ask questions or to make comments. And we also want to discuss a little bit about what's really improved for people living with this condition in the last few years, but what are the priorities for action, what still needs to be done. And our format will be a presentation and a couple of interviews and regular opportunities for Q&A. I'm sure you're familiar with this, but a quick reminder, down the bottom of your screen is the Q&A button. You can click on that and start asking questions or making brief comments right away. And we have a question monitor, Catherine Holliday, who's a researcher, a telehealth nurse, and the chief executive of the Centre for Community-Driven Research, one of our co-hosts. She's monitoring the Q&A, and as I come to her, she will direct questions, and we'll get through as many questions as we possibly can. So please go for questions even as we speak. So it's my great pleasure now to welcome our first speaker, Professor Peter Hillman, who is an honorary consultant haematologist at St James University Hospital in Leeds. I'm talking to you from suburban Adelaide, right on the bottom of Australia, but I've had the great pleasure of going to St James University and seeing the hospital there in Leeds and seeing some of the great work that's done there. And so it's my great pleasure to also mention that he's the Professor of Experimental Haematology at the University of Leeds, and he's going to talk to us today. I'll let him explain his topic, but he's been published in over 200 papers. Sorry, he's published over 200 papers, and also received a prestigious prize for an outstanding contribution to CLL research. So if you could welcome him, even if we can't see you, in the traditional deaf sign clapping manner, welcome to Peter. Thanks, Peter.
Thank you very much. It's a pleasure to join you all. Good afternoon, good morning if you're in the UK. I'm going to talk to you about chronic lymphocytic leukemia, or CLL. I'm sure you're all familiar to some extent, to a lesser or greater extent, with CLL as a disease. And what I tend to find is that in these sort of webinars, there's a very big range of people from the just diagnosed up to people who've had treatments and are very experienced. And so what I'll do is I'll talk in the first 5 or 10 minutes about the disease, how I would normally explain it to a patient. I usually draw pictures, but on this occasion, it's difficult for me to do that, so I'll probably wave my hands. I'll describe the disease, and I'll describe how we manage the disease conventionally, and then how the treatment is changing quite dramatically. I think it's important to highlight that a lot of the things you might read online in literature are really based on historic data, and the world of CLL has dramatically changed in the last certainly 5 or 10 years, and is dramatically changing almost by the month, and so for the better. So CLL is a disease of the blood, and it's important to understand normal blood so you can understand what's gone wrong in a patient's blood who's got CLL. So I'll just describe normal blood and how it works, because it's not the sort of thing we tend to retain from school, and it's probably changed for certainly me since I was at school. So in the blood we have 3 types of blood cells. We have white cells that fight infection. We have red cells that carry oxygen around, that's the hemoglobin, and if you're low, you're anemic. And we have platelets that stop you bleeding when you cut yourself. So those 3 cells last for between a few days and a few months, and so we have to keep reproducing them, and the factory that makes the blood is the bone marrow, and some of you will be overly familiar with the marrow if you have a marrow test. And the marrow is a very busy tissue, so we're making thousands of millions of cells an hour just to keep up with what's being lost, and so it has to be very carefully controlled. So, for example, if the white cell count goes too high, the body will send a message back to the marrow to say, this is my wife popping in, to say slow down, and if it goes too low, it gives it a push to make some more. So it's a bit like a thermostat. It's kept in a very tight balance. It's obviously more complicated than that. There's lots of different white cells with different jobs. And the two that are really important to know about, one is the neutrophil. That's usually the most common cell. And that's a non-specific, so it kills bacteria, viruses, funguses. It's not specific at all, but very important. So it's like a hoover, just hoovers up any bugs before they cause a problem, and keeps us safe. And the second important cell is called the lymphocyte, which you may be familiar with. And the lymphocyte is really part of our immune system. So what that means is if you get a specific infection, say measles, then one of your billions of lymphocytes will change and become an anti-measles lymphocyte, multiply and then kill the measles virus and get rid of it. That's why you get better from any viral or infection. Of course, once that's happened, you don't need billions of anti-measles lymphocytes, so they all commit suicide. Otherwise, we just end up being a lymphocyte by the age of 1 or 2. And that's very carefully controlled, but a few of those cells will live for the rest of your life and become memory cells. So you only get measles once, or hopefully COVID once, and infections like that. And so that's how our immune system works. That's how the vaccines work. So if we want to get a vaccine for COVID, we take a little bit of the virus, which can't cause the infection, give it to you, and one of your lymphocytes recognizes it, creates memory, and then if a real one comes along, it's waiting. So that's a really complicated system, and often goes wrong. And as we get older, it tends to go wrong more often, as tends to happen. And so in CLL, what happens when the lymphocyte, one of the lymphocytes is growing, it has to copy itself. So the two daughter cells are the same as the original cell, all the genes are copied. And it sometimes makes mistakes, and that's called a mutation. And then when that cell divides again, the two daughter cells will have the same mutation, and so on. So you get a family of cells derived from one broken cell. And then the body will send a message back to say, slow down, we've got enough of you. The problem is that the mutation stops the cell understanding, so it continues to grow, and the body can't stop it growing. And then it will then potentially cause a problem. And so what we see that happens in a lymphocyte in CLL, and what we see in the blood, usually in 90% of patients, they present just incidentally, where we find a high white cell count, high lymphocyte count in the blood, and often that wouldn't cause a problem. So that would be stage A, so early stage disease, or in America, stage 0 or 1. We have a different system in America, right? And we wouldn't treat patients with stage A because half of those patients will never go on to need treatment, and it will never cause them a problem. It'll cause them stress, and watch and wait or watch and worry is a very stressful place to be. So that's stage A disease. Now, of course, in some patients, those cells can continue to grow and cause a problem. And so if they do, they tend to live where they should live, which is in the blood, in the bone marrow, in the lymph glands, and in the spleen. And when those organs swell because of these abnormal lymphocytes, they cause problems. And if the lymph glands swell up or the spleen swells up, that would be stage B. So patients may then have symptoms, sweats, lethargy, weight loss, etc. And then if it affects the bone marrow and then stops the bone marrow working properly, the white cells and normal white cells, the normal platelets and the normal hemoglobin can drop because the marrow can't work, and that would be stage C. And so that's how we would define it. So it's still the right advice for patients that if you are diagnosed early, which 90% of you will be, you should not have treatment. We do have tests that will predict whether you're likely to progress or not, but there's no test that will say you definitely progress or you definitely won't progress. So your doctor can assess that. So that's where we are in CLL, but we have clear indications for treatment, and that's symptomatic disease, and that's a little bit soft. How it's hard for me is to assess your energy, the size of lymph nodes, and the blood count. So that's CLL. In terms of treatment, treatment evolved really quickly, and it's evolved because we now understand much more about the biology of the disease. So the old treatments, and we still have to use them at the moment, but they're probably going to be a thing of the past in the near future, hopefully, is chemotherapy. So chemotherapies are elegant poisons, or maybe not that elegant if you've had them. And so what they do is they kill cells that are growing. And because the leukemia cells or any cancer cell is growing faster than the normal cells, they kill them better than the normal cells. And what we tend to do is combine 2 or 3 or 4 drugs together that target the leukemia cell or cancer cell and try to spare the normal cells. But of course, the side effects to that, they're not very specific, so they cause potential problems and infections, etc. And they're pretty similar across all cancers, although they're different drugs we use for different situations. So what's changed in CLL is the understanding of the disease. And the reason I went through the fact that the normal lymphocytes grow really rapidly when they see infection and they die really rapidly when it's gone, is that's what those two things go wrong in CLL cells, and that's why we have a problem. So what happens normally is a normal lymphocyte will makes antibodies, which are specific proteins that attack, in my case, the measles example, so anti-measles antibody. And what the lymphocyte does is it puts it on its outside of its cell, it displays its own antibody and waits for measles to come along. And if measles comes along, it starts to grow because it sees the measles antigen, the measles virus. And then once it's gone, it stops growing. So that pathway to make it grow is a very organized pathway. And in CLL cells, what happens, it tries to do the same. So it makes its own antibody, puts it on the outside of its CLL cell, but it stimulates itself. So it doesn't need a measles virus or something else. And so it's constantly growing because it stimulates itself, but it uses the same pathway. So what we have is small molecules that block the pathway and stop it growing. So the proliferation of the disease, which is one of the two major problems, can be switched off. And the diseases, the treatments that do that are ibrutinib, that's the main one that we have, but there's also a series of other next generation, even more specific ones, acalabrutinib, zanubrutinib, and idelalisib. They're the drugs that are small, tablet forms that switch off the growth of the cell. And our trials in both relapsed patients and in frontline have shown a dramatic effect for certainly ibrutinib, with some side effects which we have to manage, and that's why we have the next generation ones coming along, which are actually now, being licensed. So we've done lots of trials on them. So that's a really important development. That's made a major impact on the outcome for patients. And patients who previously might have failed chemotherapy or might have had what we consider 17% bad disease for chemo respond very well usually to that type of treatment, and their survival is much better. And so when you look at the survival curves from 10 years ago, that was before we had ibrutinib or any of the drugs. So that's the first pathway we can target. And the second one is the death pathway, or apoptosis. So when a cell has finished doing its job, killing measles, you've got these thousands of millions of anti-measles lymphocytes, you have to kill them, and that happens through a very specific trigger in the cell that makes the cell kill itself. That's called apoptosis. That's a series of switches again. And in CLL, one is always switched on to stop it dying. So the cell can't die. So we've got a double whammy. It grows too quickly all the time and can't kill itself, and then it accumulates. That's the problem. What we have now is that one drug, and there's more being developed, which switch off that switch and make the cell kill itself. And so that the one we have at the moment is called venetoclax. In fact, it was developed to a large part in Australia, in Melbourne. So Melbourne's been really at the centre of the development of venetoclax with Boston as well. And we've done a lot of work in the last 8 or so years with that drug. And that's a really effective drug at killing leukemia cells as well in CLL. And by itself has made a big difference. It's about 2 or 3 years behind ibrutinib. And so we've had when we do trials in CLL, and leukemia cancer generally, we generally would want to compare the new treatment with the older treatments, so the chemotherapy. And we would usually do that in a situation where the chemotherapy doesn't work very well, because we get a quicker answer. So if with our best treatment with chemo, it takes the average time in remission 5 or 6 years, that's too long to get a quick answer. But if you take someone who's failed chemotherapy, you get a much quicker answer. So that's why you tend to see these drugs approved first in patients who have failed therapy before it comes into the front line where treatments are better anyway. And so we had ibrutinib, it's been approved for several years now and is very effective. We've had venetoclax, we've combined venetoclax with other drugs to make it better, and it's very effective at getting rid of disease. And so for both, I think in Australia and in the UK, from probably 2 or 3 or more years, we've had approval for ibrutinib and idelalisib and venetoclax with an antibody in relapsed disease. So the next step is to move that, because all our evidence from all of our trials, and we've run lots of big trials, is that if you use your best treatments first, not at the end, you get a better outcome. So if we're going to cure CLL, and I'm a believer that we will cure CLL, we're going to do it in frontline, not stage A. So those of you who watch and wait in stage A, that's still the right treatment, because as we get better treatments when you progress, then it doesn't matter if we treat you later, because they're effective treatments. So although it's a scary place to be, I just to reiterate, we wouldn't change much where we would in the indication for treatment. So we've now done trials of ibrutinib in frontline. We started them actually, the first one 7 years ago, and that's shown dramatic responses. And so we're seeing much better responses just to that tablet. It's given continuously until progression, which is a long time in frontline, but very few patients become resistant to that when it's used in frontline. The issue for ibrutinib is there are some side effects, particularly heart side effects, other nuisance side effects, and about 20% of patients stop the drug because of those. And that's why we have the next generation ones coming along, which hopefully seem to have less side effects going forward. And that's the natural history of drug development. You find a drug that works, and then you try and make it better by using a more specific one or combining it. And so that's been around, and it's now starting to be approved in frontline. The issue for the UK, and the issue also for, I think, Australia and most healthcare systems, is if you're giving a drug until progression, that's a lot of drug for a long time. So therefore it's very expensive. The side effects are there all the time, which is a nuisance. So you can cope with the side effect for a year or two. For the rest of your life is a challenge. And if you're going to have resistance, that's how you encourage resistance, because if you're on the drug, the cells learn and avoid it. If you give it for a short period of time and stop, they can't learn to become resistant. And then you might be able to use it again in the future if you need to. With venetoclax, we're a little bit behind, but we've had data now from a big trial from the German group who run, showing that venetoclax with an antibody, which is a relatively non-toxic drug, shows very deep responses in frontline, and is better than our weaker chemotherapies. And the advantage of that approach is it's 12 months of treatment, and you stop. Now, we can argue, we can discuss whether that's the right approach, because in our trials we're much more guiding it by each individual patient. But the important thing with venetoclax is it's a fixed period and then stopping treatment, which is where we all want to go, I think. So that's where we are now, and those drugs are going through our funding processes certainly in the UK, and I think in Australia at the moment. And unfortunately, that involves a lot of wrangling, and COVID's not helped in terms of the speed of process, but we're hopefully getting there. So that's where we are at the moment, and that's what the evidence is. In the last few minutes, just where we're going in the future. Well, our aim, as I said, is to try and cure CLL for as many patients as we can. Some patients may not need, if that's probably the wrong word to pick, cure may not be critical. So if we can control it like we control hypertension, and it never causes you a problem, then that might be a better approach if it's a much milder approach than an intensive approach to try and cure it. So that might be depends on what else is wrong with you, what your age is, what your aims are. Lots of things will impact the decision of who to treat how. But all these treatments work, so that's important. So we'd have that discussion with the patient. So in order to cure CLL, we need to eradicate the disease. So if we're going to stop therapy, we need to get rid of it until we can't find it. So we've invested a lot of effort in developing tests to look for low levels of disease and to make sure we can detect really low levels of disease, or what in jargon we call minimal, so the lowest residual disease, or MRD. And an MRD negative remission would mean we can't see it with our best tests. And conventionally, we do that test that will pick up a single CLL cell in 10,000 normal cells. And in fact, now we can certainly go down to a single cell in 100,000 cells, and with some tests, 1 in a million. Still means there could be some cells there that we can't see, but it helps us understand how to drive people into deep remissions. And with what we've started to do in the trials is to combine the two main drugs I described. So the ones that stop the cells growing and the ones that make the cells die, venetoclax, ibrutinib, the other way around. And if you combine them together, we've done that in relapsed patients, we're seeing really deep remissions in most patients. And when you start doing that in frontline, we're seeing 3/4 of patients with no detectable disease. So really impressive compared to even the chemotherapy era. And so they're now, in the last couple of minutes, the trials are ongoing. Certainly in the UK, we've got the largest phase 3 trial. That means a big trial that proves that it works. That usually involves hundreds of patients, and called the FLIR trial. And that's currently got almost 1,500 patients recruited from the UK. It has 2 questions it's asking. The first one, because it's been going for 6 years and we haven't quite got the answer yet, maybe next year we'll get the answers, or the first answers, is ibrutinib versus FCR. So can we beat chemotherapy in frontline for all patients? So that data should be out soon. But the second question, which I guess is the most sexy question now, is the combination of ibrutinib plus venetoclax together in a frontline patient. And we've have over 250 patients now treated with that combination in frontline, compared to randomized to compare to FCR and ibrutinib. So that'll prove whether we can use therapy like that to stop a deep remission and see if that cures or certainly improves the outcome for patients. And the Germans have a similar trial which uses I plus V, which is those 2 drugs plus an antibody, so 3 drugs. So the question with that is, if you add more, does it add benefit or does it add side effects? And so it's important we have these two large trials, which will both probably report sometime in the next 12 to 18 months. And there are other trial groups in North America going on looking at similar questions. So we're all working together really to ask slightly different questions to see which is the best combination to take forward. So I'd encourage you, if you have CLL, so just the last minute, if you have CLL, stage A, you will need to understand it. You need to be confident about your doctor understands it and you have a good relationship with him or her. But you don't need to be treated. Okay, so there's no evidence of treating early is better. We have good treatments. It's important at the point of treatment you make that decision and you understand and you have your input into that decision. There's a lot going on in the world of CLL. I've already talked about the current frontline stuff, but there's also relapse and other trials going on later on. So clinical trials are important, and usually we have evidence from a number of diseases that if you go into a clinical trial, outcomes are generally better. So if you have a trial available, I'd ask if there's a trial available, and then you can make an informed decision as to whether you go into the trial. And finally, the world of CLL has changed dramatically, and 10 years ago, I often sat in front of patients who had failed treatment, and we tried, been doing these trials for many years, really without much hope that we're going to make a big difference. And now we're in a completely opposite situation, that even in patients who have failed 2 or 3 lines of therapy, we still expect to see good responses. We don't always see them, we can't guarantee it, but I think we're really in a very optimistic place in terms of the treatment of CLL now and in the future.
Thank you so much, Peter, for that incredibly clear and very comprehensive talk. I'm going to invite Catherine in to bring questions from the audience, but just very quickly before Catherine begins, just explain what frontline treatment means for everybody.
Yeah,
but also my second point is, just quickly, is why are the names of drugs so weird, so hard to remember? Is there a particular rule of nomenclature that makes them these weird words?
Yeah, so there's a lot of jargon. It's hard to slip out of jargon. So frontline basically means a patient who's not had treatment before. So it's their first treatment. And then if you've had treatment and then you relapse, that would be a relapsed patient. And then if you fail to respond to 1 or 2 lines of therapy, that would be refractory. And of course, it depends on what treatment you've had. Yeah, the naming of drugs. There's a naming committee actually, which names drugs. There's a challenge because if you have 2 drugs with very similar names, there's a danger there that apparently some doctors don't write clearly and pharmacists get confused when they see drugs. So sometimes you have a really nice name for a drug, but you can't use it because it's another drug's being used that way. And so when you look at it, so I'll just describe the 2. So ibrutinib, inib is a small inhibitor of a pathway, whereas umab is a human antibody. So that's the end of it. Clax is an apoptosis drug, so venetoclax. So the end of it tells you what the drug does, and then the earlier bits are either what type of disease they have. So umumab would be tumor human antibody. So the back half is that, and then they basically have a relatively random bit at the beginning, which has to be different. And so now we've had so many drugs, it's really been a challenge.
Well, thank you for that. This is something as a patient I struggle with sometimes, and how interesting. Catherine, over to you. Thank you.
Thanks, Julie, and thanks, Pete. That was fantastic. So we got a lot of questions in when people registered, and a lot of comments. Most of the comments were, thank you for making this opportunity possible, and I can't wait to hear what Professor Hillman has to say. So it's been wonderful. Some of the questions coming through, for someone who's just starting treatment, what should they expect in terms of side effects? And is there anything they can do to reduce the impact of side effects? And a second question is, do you think the pandemic has affected CLL research?
Yeah, so in terms of side effects, it's very specific to what treatment and to the patient. So chemotherapy obviously has very characteristic side effects. You can have more intense, less intense. CLL chemotherapy is not the most intense chemotherapy. It's mainly outpatient based. Sickness, low white cell counts are often an issue. And in terms of the targeted treatments, the ones I described, we see side effects with those, but it needs to be managed. So we might, in some patients, if we had the choice, select one therapy because of what drugs they're on, or if they've got diabetes, or they've got heart problems, or other issues. And so it's very specific to the individual drug and individual patient. I think what's important, and certainly in our practice, the discussion with obviously the hematologist, in our case, or oncologist, if that's who manages you. Discussion with the nurses. We have clinical nurse specialists who will give contact details to patients, and they have a contact point if they have any questions they don't want to bother the doctor with. I mean, they should be able to bother the doctor, but patients can't always get hold of them. And the pharmacist actually has become an important member of the team to look at drug interactions. I mean, some of our drugs interact with other drugs, and so it's about information and the patient understanding, what's expected, what's acceptable, and what's not acceptable. And because what you don't do is sit on side effects, which are important, and we can tell you where they are. COVID has had a major impact clearly on our practice, and so it's clearly worried patients. I mean, we know CLL patients are at greater risk than COVID of getting more severe disease and potentially dying of COVID. So protection and avoiding being exposed to it is really important. So we saw that in our FLAIR trial, that in the first 2 or 3 months of the pandemic, we had about 15 cases, and we had very few, if any, since then, while patients have been shielding. And so it works, and it's important. And we understand a lot about COVID, and that there's lots of asymptomatic people around who you won't know have got the disease, who are a risk to you, and it's a challenge because we've got children, we've got grandchildren, it affects our life. But the reality is we will get through COVID, inevitably, and it's a matter of keeping safe until we do, and keeping sane until we do as well. I think that's a challenge. In terms of the treatment, we've certainly joined the peaks, and we're just in the second peak in the UK now. Avoiding contact with the virus is important, and therefore spending time coming into our hospitals is a challenge, and patients are scared to do that, and we don't want them to come to do that. So we've moved to telephone and video calls, remote blood monitoring. We've also changed our treatments a little bit, because certain treatments like venetoclax require a lot of visits to hospital initially, 3 times a week for 5 weeks, which is a challenge if there's lots of virus around as anxiety, whereas ibrutinib is oral and can be given at home. So it has changed a little bit the way we treat patients. It's also, I sort of try to be clearish about the indication for treatment, but it's a bit of a movable feast, because it depends on your symptoms, how you feel about the disease, how your energy levels are, how big the glands are, do they trouble you. There's not many patients where we say we have to treat you today in CLL. We normally have some flexibility, and I think what COVID's done is meant we've delayed treating some patients where we have a little bit of choice, and we've said to patients that we'll wait for a month or 2 until we feel it's a bit safer. But we can't do that forever, and that's the problem. So we're now, sort of in the UK, in 8 months into the real pandemic, and we can't wait that long, and so we've had to modify the way we work in hospitals. So the final thing to say about it is we're getting better at managing it in hospitals, and so you shouldn't be scared to go into a hospital. You shouldn't be volunteering to go in if you don't need to. But if you have a complication or a problem, it's very clear that people are not being diagnosed with cancers because they're scared to go to a doctor or a hospital, and that's the damage of COVID. One of the damaging things of COVID coming through.
Thank you so much. There's other questions that have come through, and for everyone, we can't answer them all, but we'll try and get back to you via email. Thanks so much.
Peter, thank you so much. And for those who can be seen, if you could do the deaf sign clapping, because we really appreciate it. And thank you to Professor Peter Hillman from St James University Hospital, Leeds. If you do need to go, of course, and if you are able to stay, that would be marvellous. We're going to do a short interview with a representative from Australia, and then we'll have some more Q&A if you're able to stay.
Okay.
So welcome now to the Chief Executive Officer of Lymphoma Australia, Sharon Winton. She's a member of the Lymphoma Coalition, and she's been a consumer representative on a number of stakeholder groups in Australia and internationally. So welcome to you. I'll give you the deaf sign welcome. We had a chance to speak earlier, and we're going to talk about what you think has improved in recent years and what are the priorities of what still has to be done. But just before we get to that, you passionately believe that patients need to take action to inform themselves, that power comes with knowledge. Will you speak to that? But also, in reaching out to learn more, how do you avoid misinformation once you get into the world of the internet or the patient group where not everything may be evidence-based?
Exactly. And thank you so much for that question, because definitely for patients and everybody, knowledge is your power, but you can't let it overwhelm you either. So when you are diagnosed with CLL, you do actually need to know what it is, but you also need to remember that it's going to be unique to you. So that's why we're saying you need the knowledge about your CLL, not just CLL in general, because if you just went and Googled CLL, what you might read may not have any relevance to you at all. So to your question then, how do you then decipher all of that? Yes, that can sometimes be difficult. And I think even Peter would say, don't just Google, because that's scary. But go to organisations that are trusted sources of information, like the Lymphoma Australia, Leukemia, the Leukemia and Lymphoma Associations in the UK. Ask your treatment team, where can you go? And also what we're seeing now globally is this connection between patients and everybody through online forums and everything else. Again, they're great ways to connect, but be mindful of what you are reading and taking in sometimes.
Yes, I think when I have been a cancer patient myself, and when I said to my team, what website should me or my friends look at and what not? And I took that direct guidance. But let's go to some of your key messages. You say that what has improved, and we're talking obviously here about Australia specifically, but there are more treatment options approved by our pharmaceutical benefit scheme, the provision of cheap or free medications. And those greater treatment options are the result of research and clinical trials. Can you speak to that, the good news?
Yeah, look, definitely. As Peter said too, a decade ago, what a CLL patient would have been treated with is entirely different to what we're seeing today. And that's been the result of research, genomics, clinical trials. And the good news then for the CLL patient of today is that there are treatment options that are available to you that we've never had before that are extending lives. And within Australia, and the same with the UK, I think we've been very fortunate that we do have health systems that have brought through the ibrutinibs, the elacibrutinibs, the venetoclax, even though it is in the relapse setting. But then listening to Peter, it's great these trials are now pushing it into the frontline setting as well. So for a CLL patient, what you've got today is great. What you need to know, though, is what is relevant for you individually as opposed to everybody, so that you get the right treatment sequencing for your CLL. And that's that knowledge piece that I was speaking to earlier as well.
And you also say the good news is that there are more treatment options, and that's leading to better survival.
Well, yeah, you can actually, that we know what we're doing now a lot better. So even with the diagnostic side of things, and this is what part in Australia where we are lacking a little bit, we've got the diagnostics and the testing that can help guide the treatment decisions. but we don't have it all funded yet in Australia. So we have an inequitable access to that. So to the Australian patients here, make sure you are asking to be tested before you are treated, because it doesn't always happen. So ask what test you're having and then ask what the answers are as well.
You've raised this issue of equity of access, and I don't know if we want to get a comment from Peter later. I'll leave that to Catherine. But your feeling is, in the Australian context, despite our universal health coverage, that there is a difference between public and private patients, or locations of where you live or don't live. Like, where does the inequity come in terms of access to the right test at the right time?
Testing is your diagnostic, so it's things like your fish test and that. So we don't have it funded yet in Australia. I'm not too sure how it works in the UK. So it may mean that as a patient, you need to know that a fish test could be relevant for you, and you ask the clinician. So that's that knowledge piece that will then help with the treatment. So we've got some inequities there. Once a treatment is approved under our PBS, then it is becoming equitable, but that's when it's of knowledge of knowing the sequencing of treatments for you. It's up until the approval process in Australia where you would want to be looking at your clinical trials, and COVID has probably been a bit of an impact now as well. It's like, once upon a time, we might have travelled a bit further for a clinical trial, whereas now we'll stay closer to home and we might miss out on some of those treatments. So there's that potential inequity there as well.
And that's another key concern of yours going forward, isn't it? About providing accurate and more accessible information about clinical trials to patients who may benefit from them.
Yeah, definitely. I mean, Australia, we've got geographical challenges. Most of our population along the East Coast, that's where we're going to put the trials. So rural, regional patients, getting that information. So for patients and everybody online here tonight, today, whatever it is, you do need to keep abreast of these trials. The ones that Peter were talking about are brilliant trials. Can we bring them to Australia as well? We'd love to have those combination therapies. But we have a right to ourselves. We need to actually be looking after ourselves and sometimes advocating for ourselves, and that's needing that information.
Sharon, I want to come back with one more question before we go to open questions, but if I could come to Peter Hillman just for a moment and just say, do you have any issues at all about equity of access to testing and treatment in the United Kingdom, or is that not an issue with the National Health Service?
In terms of treatment, the diagnostics, and that's moving rapidly. So in terms of sequencing of patients, which understanding what genes are broken, and there are some things that actually affect treatment now, and others that are going to affect treatment going forward. We have a very good platform of diagnostics in the UK, and patients don't pay for it, so it's available generally. Although I think as Sharon said, the clinician has to ask for it and has to understand the importance of it. And not every clinician is a CLL expert. We have the advantage in both the UK and Australia is that we're managed by haematologists. And so at least they're blood specialists, not cancer specialists. And that really matters as our diseases become much more specialized. So some of us just manage CLL, not lymphoma and other leukemias. And that's, so I think part of it is getting the right advice and asking your clinician, is there anybody else that you should get a second opinion from? And if I find if a doctor says you shouldn't have a second opinion, then you're probably with the wrong doctor. I mean, I think you need to get that information. In terms of treatment, the advantage of our socialized system is that if it's approved, you get it, and that's good. So everyone should get, and it's not faultless, should get the same treatment. The problem is it's slow. So ibrutinib we've known as being a better treatment for the last frontline for many patients the last 2 or 3 years, and it's not approved, not funded yet. And so I think lobbying and there's 2 very good, strong groups in the UK for CLL patients. The CLL Sports Association and Leukemia Care are the 2 ones that are very prominent in CLL. A lobby with the government to get these things funded. I mean, advocacy is really important, and patients' advocacy is critical to make sure we have access early. We don't want treatment which isn't proven to be good. We don't want hydroxychloroquine for COVID. We want to prove it works, and once it's worked, we want to have access to it. And so I think the approach is right. we need to keep the pressure up.
Sharon, just one last question, then we'll open up to all questions, and that is, just tell, for those in Australia, what do you offer, what does Lymphoma Australia offer patients and families with CLL?
Yeah, so with CLL and any other lymphomas as well, we want to be able to provide that support and information so that regardless of where you are living or where you are in your journey, you can actually come to us for help. And so we do have our lymphoma care nurses, as well as our website with all the dedicated information, our support materials. But education sessions like these are also invaluable for any patient with any disease, so that you can actually take that away and then discuss it with your clinicians. So these sorts of sessions are what we can offer as well.
Well, look, Sharon, thank you so much. I'll just give you the appropriate clapping, if you get clap back, and I'll hand over to Catherine now. We've got 10 more minutes of question time.
Okie dokie. So just a couple of questions. So the first one comes through as, are there any differences in the way that older patients are managed compared to younger patients? And I won't make any comment on what's an older or a younger patient. And another question is, what are some of the most common questions patients ask when they're newly diagnosed?
Yeah, age is obviously a movable feast, isn't it? Because I had to sign a 50th birthday card for one of our staff yesterday, and someone next to me said, "Oh, that's old," and I thought, "What? Wait a minute." So it affects patients' approaches to the disease. So if you're in your 80s, you may not want to have intensive therapy. You may not want to travel. There are other family members that participate in the discussion and the care. If you're a younger patient, and it's not only age. I mean, it's obviously your attitude as well as an individual, whether you want to go for more sort of assertive a treatment approach to try and get off treatment and be in a long remission, and that tends to be, the younger patients tend to be more likely to go for that approach. But I think it's very much individual. It's not defined by age. Certainly in the chemotherapy era, there are certain chemotherapies you wouldn't give to older patients, because we know they don't tolerate them as well. So FCR has always been a difficult one for patients over a certain age, or with comorbidities or other illnesses that interact. That's becoming less of an issue in terms of age with the new treatments. Ibrutinib, venetoclax, acalabrutinib, they're becoming more specific. So, for example, someone with a significant heart problem in the past, I would be anxious about ibrutinib. Someone with significant kidney problems, I'd be anxious about venetoclax. Wouldn't mean I wouldn't use it, but it would sway me to a different approach if I could. So it's much more what drugs you're on, what all the health problems are, rather than specifically your age.
And to maybe to Sharon, when patients are coming through your support services, through your nurses as well, what are some of the main questions that they're coming with?
Mainly, if it's an initial diagnosis, is understanding the diagnosis. And I think with any chronic blood cancers, when, particularly if you're diagnosed at a later stage, people often automatically go to, "Oh no, this is really bad," whereas actually we can actually then explain, "No, this is a totally different scenario to a solid tumor situation." So I think that's a really important part. But then it's also those the side effects of treatments, or the treatment options, and particularly when patients are talking to other patients and one patient's on one treatment and another patient's on a different treatment, or clinical trials come into play. So it's trying to unpack all of those problems that are around what is available for them.
And I think that the last question we'll ask is around clinical trials, and to both Peter and Sharon, how, I guess the language, how clinical trial literate do you think patients are becoming? Is it becoming more common for patients to come to the clinic and to their clinicians and ask about trials, or is it still quite driven by their clinician, that discussion?
Yeah, I mean, from my perspective, because my patient group is, some of them are from our Leeds area and Yorkshire area, but many of them come from far afield and are very informed about the disease and about trials, and so will travel for the trials, in fact. I think because our unit's very focused on trials, there's information about trials everywhere. So most patients not all, but most patients are familiar with trials before we have a discussion about it and not anti it. I think just to describe trials, I think because individuals, patients, families think about trials and guinea pigs and you know, they're being experimented on, and I guess that's true in some respect, but we don't just pick a regime out of the fresh air. You know, these are highly organized. So just to describe trials, if we get a new drug, we would not treat a frontline previously untreated patient with a new drug with no evidence, with not knowing the side effects. So we would go through a phase of trials, which phase 1 is where you're actually looking in even normal individuals. That's what's going on with the vaccine trials now, to look at safety and is there any sign of effectiveness. And those trials would be really focusing on patients who have failed chemotherapy, have got, you know, limited options, rather than and obviously the more options we have, the further down the line those patients are. And then after we get a safe dose, which we think might work, we do a phase 2 trial, so we treat maybe 50 or 100 patients with the same regimes, not randomized, same situation, see if it works. And so we have increasing safety data, so we know it's safe, and or it's not very dangerous. We collect safety data throughout. And then the phase 3 trials are the ones which prove it works. And so compare ibrutinib versus FCR or hydroxychloroquine against steroids, or whatever the trial is. And they're really important because they, I can think a drug is better, but I might not be right. I can think that, you know, hydroxychloroquine works and take it, but that's, you know, we might poison ourselves doing that. There's lots of examples of that happening historically. And so the phase 3 trial is really important that I don't choose. It's randomized. It's difficult for patients because you know, you have to be prepared to have the randomized treatment, and we tend to do them in situations where, you know, if you've got ibrutinib available anyway, you're not going to go into a trial where FCR is your comparator. That's fine, but we don't have that, and so at the moment, so we have to do the randomized trials. But they're safe, both in those phase 3 trials. All the 3 arms we have at the moment open and for that are all good treatments. They all work. We have evidence that they work. It's just which is the better and which is the safest. And so I'm encouraged to learn about trials, ask questions. The information sheets are mind-boggling now. And when I did my first trial 25 years ago, I wrote it on my own computer. My information sheet was 3 pages long and understandable, hopefully. Now they're 30 pages long, and they've got legal talk about, you know, this, that, and the other. So don't get bogged down by the language, because it's, you know, it's just the way the world's moved. Ask questions of the trial nurse, ask questions of the doctors. Make sure you're comfortable about the trial. You should never feel obliged to go into a trial. And I always make a point to say, look, we have these options and it's your choice. And it doesn't matter if you go in the trial from my point of view. We've got lots of patients going to trials. You've got to do the right treatment for you. And it may well be a trial, but it may be that you don't want to go in a trial because you don't want to have one of the treatments. And just be informed.
Peter, thank you. I'll get a quick comment from Sharon, if I may, because we've got Neil Matthews just waiting in the wings for our final segment. But a quick comment, Sharon.
Yeah, I just probably like to say, yeah, community awareness of clinical trials in Australia has probably got a long way to go. We need to be better educated around it. And also, we tend to have hubs of trials in Australia. So if you're not within one of those hubs areas, you may not even be informed of those trials. So again, it's about patients informing yourselves. So look on the Clin Trial Refer app or go to clinicaltrials.gov.au. I know it's complicated, but if you have a problem, call organisations like Lymphoma Australia so we can help you through it. Because sometimes, because our system can be so slow, you need to be on a trial to be accessing the best treatment as well. So that will be your way of getting those better treatments too. So keep an open mind, but must ask questions around clinical trials.
Well, look, thank you very much to Sharon Winton and also to Peter. If you're able to stay, Peter, we're just about to talk about the patient experience just for 8 minutes, but I know you have a pending Zoom. But it's my great pleasure now to welcome Catherine Holliday, first of all, who's been our question monitor. You'll remember she's the Chief Executive of the Centre for Community-Driven Research, and also Neil Matthews, who's a patient advocate. And you're both part of the PEAK study, and PEAK stands for Patient Experience, Expectation and Knowledge study. Perhaps I could just quickly start with you, Catherine. What's the purpose of this study and what's been basically happening?
So peak studies are a series of studies across a lot of different disease areas where we acknowledge that the patient, the person diagnosed with a condition, has expertise, that they're an expert in their condition. So we want to understand what their experience has been like so we can learn from them as clinicians, as researchers, as decision makers in government, but also ask them what they think should happen in the future in relation to treatment and care and information and support to give us that pathway of what has to happen next.
So who have you spoken to? Is it only patients? Do you speak to family or anyone else?
So the study is open to patients and also people in their family, because as most people will know, it's a bit of a family affair when you're diagnosed, particularly in an oncology setting. Everybody has a role to play and everyone has to have their say as well. So family members are welcome to join as well.
Well, look, I'll come back shortly and ask you when the information will be released and how you think it can be used in advocacy. But first of all, we've talked about family, so it's time to meet Joanna, who is the wife of Neil Matthews and who is completely responsible for his technology. So welcome to you both. I'll give you the welcome clap from the bottom of Australia. Yeah. Neil, you were interviewed, were you, but can you tell us your experience of being part of the study?
Yes, well, I thought it was excellent because, as Peter said, and as we mentioned earlier, we're in the world of international advocacy now for CLL, and to achieve that information, we need to convince the likes of the Pharmaceutical Benefits Advisory Committee in Australia of the benefits of new drugs and improving the quality of life for people with CLL and other conditions. We need to find out solid evidence of what it's like to live with the disease and what can be done to improve the quality of life and the life ability of people with these illnesses to be able to continue functioning in community and supporting their families, friends, the community, and so on. And so this is where the CC is very important in terms of collecting this information. We've now managed to get 65 people in Australia and their carers and so on, so patients and carers, to share their experiences. And it's a very good process of going through the process of diagnosis, living with the watch and wait, and then if they've got through to needing the trial or treatment, how they went with that and the kind of support they got. And by that, finding out where the gaps are. And in fact, we've just had recently due to the efforts with Deborah, who's now on a CAR T treatment, working with an Australian parliamentary group to actually get a plan for the action plan for CLL in Australia out for the next 15 years, and identifying things we needed to improve the outcomes for CLL. And as Peter Hillman said, one of the very important things with CLL is that it's changed so very fast, and if people go to Google never forgets, and it's very easy to get information which is 10, 15 years out of date, totally inappropriate for circumstances. CLL is a very heterogeneous illness, and it's just so complex nowadays. You do need to get yourself to a hematologist who knows about the disease and knows what would best suit you. And bear in mind, when you look at the survival statistics of CLL on Google, it takes 10 years before you find out how long someone survives, beyond up to 10 years. So the information in Google is 10, 15 years out of date in terms of survivability times.
That's a very important message. Can I just ask, because we've got such limited time, what are the 2 or 3 changes, improvements you want to see in the patient experience? What are you mainly advocating for? And I might ask your views in a moment, Joanna, from a family perspective. But for patients, what's your 2 or 3 key goals for the future?
The critical thing in Australia is finding the means of getting expert access to a knowledgeable hematologist in CLL. It's changing so rapidly. It's a constant job just keeping up with the improvements. And as part of that, you need to be able to press your current specialist to make sure they do know the knowledge. That's where I'm an administrator of the CLL support online community on Health on Life. We've got 16,000 members. We're proudly evidence-based. and we can help people understand, like they share where they are, where they can go to get that level of support. The critical thing in Australia is knowing where you are, what you kind of likely, do you need treatment? Like Peter Hillman said, you may never need treatment. And if you do need treatment, what are the signs? And then what's most appropriate for you? And therefore, the critical thing in Australia is getting tested to find out whether, in fact, the current treatment you're most likely to get, which is a chemotherapy treatment like FCR, will actually do any good for you. Quite often, sometimes you just won't respond well to FCR, and there are critical treatment tests that you need to be able to get, and they are, unless you know about them, you may not even ask, and your specialist, and they do see a lot of CLL treatment, CLL patients, they won't even know to ask and arrange for that testing. So the critical thing, I believe, in Australia in the future is to get a greater knowledge of, for haematologists in Australia, of what testing is available in Australia, where to get it, and to make sure their patients get it before they start on any treatment course, so that's the best treatment for them.
Well, thank you. And Joanna, as a partner, a wife, what's the change you most want to see, or the improvement?
Yeah, I agree with what Neil said. I want to add that in Australia, a huge problem area, as I see, I'm from Europe originally. I moved here 3 years ago, and I see that the distances from those hubs are unfortunately a problem, and the distances patients need to travel with their family and pack up their entire life and house. Those gaps, they just make it very difficult for people to access treatment. So if you live in a regional or rural area, which can be a small city, for example, it gives you less chance to access treatment. And if you live in big cities like Melbourne, etc., then you just have better chances to get the testing, to get the access to clinical trials, just because you're already there. So there's a strong inequality there.
Thank you so much to both of you. And just before I come back to Catherine to make final remarks, Peter, could I ask you this quick question, because I can see you're still there. Here in Australia, we have lower survival rates in most cancer areas if you live in rural areas. To give you a sense, when I drive home from where I am now, I'm actually going to drive 1,800 kilometres to go back. Now, that's a long drive, but a lot of Australians do very big drives. Do you have similar differentials? If I'm in the north of Scotland, or, do you have similar problems with distance, or is it different in the UK just because you're so much smaller?
Certainly, I'm sure it's very different. Having been to Australia a number of times, the distances have an impact. I mean, I think there are other factors that affect rural communities that as well as the distance from the centre that have an impact on health generally, and therefore outcomes for treatment. So it's not only the distance, although that clearly makes a difference. I think actually in some ways COVID might have helped. We now are used to doing video and telephone consultations, and distance is therefore less of an issue. And certainly I'm getting referrals from all over the UK now and doing telephone calls with some patients, and that makes a difference. And then some of these treatments can be delivered in the rural communities. It's just knowing what treatment to get. And so I think that will improve. But access to trials, I agree. We've had people from all over the place to come for trials. My record's Brazil. I had to live in Leeds, and so he didn't like Leeds. It was too wet and cold, so I had to go back after a few years. But so patience, determination is important when you have a challenge to overcome, such as distance.
Yes, I must say I admire the man or woman from Brazil who, and their thirst for life. Thank you so much to Neil and to everybody. I've really learnt so much, and I'd like to hand back now to Catherine for closing and farewell remarks. Thank you.
Thanks so much, Julie. I'm just going to pop Sharon back on so we can thank her properly as well. Thank you to all our speakers. Thank you, Julie, so much. Always a delight to work with you. Neil and Joanna, thank you for your participation and for all your support with the PEAK study. For those that haven't had a chance to have their say yet, we'll be sending out some information after the webinar, and also some of those links that Sharon spoke about with clinical trials and how to find the support and information you need. So to everyone, have a great day. Thank you all for coming, and we'll see you soon.